If you wanted to look at a controversial area in terms of pancreatic surgery, you have to look at cystic tumours of the pancreas. And really this is a growing problem, and it's a growing problem because of the use of CT scanning, MRI scanning, and as we heard yesterday, the increased use in terms of CT colonography, etc. We're now seeing a massive increase in the incidental finding of pancreatic cystic lesions. We can see here on the CT scans that cysts within the pancreas can range from simple unilocular cysts to multiseptated cysts with mural nodules, etc. In terms of MRI, we have seen an increase in 20% in the use of MRI. MRCP is now performed in up to 45% of people for non-pancreatic indications. And so our clinics are full of these people coming with cysts on their pancreas. The problem is that when a person is told that they have a lesion on their pancreas, they instantly think that it is pancreatic cancer. And they instantly relate to those well-known people who have sadly passed on as a result of the terrible disease that is pancreatic cancer. So when they attend your clinic, they come full of fear with regard to what you're actually going to tell them. And the problem is, for pancreatic cystic tumours, the range is from those that are clearly benign with serous cyst adenomas, or even the simple pseudocyst, which is the largest component of cystic problems that we see in our pancreatic practice. However, the problem is there are those cystic tumours that are either pre-malignant, malignant tendencies, or are actually further progressed to invasive malignancy. And that is the mucinous cystic tumours, the main duct IPMT, the side branch IPMT, and the pseudopapillary cystic tumours, which I'll address shortly. The other problem is that surgery for pancreatic disease is major. Surgery is either the form of a Whipple's, which is taking away the head of the pancreas, or in terms of a distal pancreatectomy, taking away the body and tail of the pancreas with or without the spleen. It is major surgery, and unfortunately with major surgery comes not only mortality, but significant morbidity. So in terms of a Whipple's resection, as you can see here, it looks like a string haven, you have up to 30% morbidity, pancreatic fistulas, major hemorrhage, delayed gastric emptying, etc. And so performing that type of surgery for benign disease is extremely challenging. Performing that type of surgery for disease that may, in 5 years, 10 years, become malignant is also challenging. And it's not as clear-cut as if this was a true pancreatic ductal adenocarcinoma. Similarly, subjecting a 20-year-old female to an operation that's going to remove her spleen and have a lifetime of antibiotics, as well as the complications, is not without its challenge. And so how do we assess cystic tumours of the pancreas? It's actually quite difficult. However, we use cross-sectional imaging, CT and MRI, as has been demonstrated. We are now in a world where endoscopic ultrasound has helped us greatly in the detection of small tumours within the pancreas. And there is certainly an indication for the use of EUS in terms of these cystic tumours, not only in terms of detecting them, but also in terms of the characteristics of the cyst, and probably more importantly, being able to aspirate the cyst and check the tumour marker contents, with particular emphasis to CEA. CT PET really hasn't any role to play in terms of cystic tumours of the pancreas, and I would probably challenge the role of PET even in pancreatic adenocarcinoma by Steve Strasberg and his group in Washington. So CT and MRI will give us an essential idea about the characteristic of the cyst. Where is it? Is it unilocular, multilocular? Is it septated? Is it linked to or involving the main pancreatic duct? And each of these are extremely important in trying to decide who can we watch, who do we need to watch carefully, or more importantly, who do we actually need to take to surgery. Basically, endoscopic ultrasound, as I said, is an ideal opportunity to look very closely at small lesions, but more importantly, to take out fluid from the cyst and to send it off for CEA. If you only get a small amount of fluid out, you don't really want to waste that fluid sending it off for amylase or sending it off for cytology. Unfortunately, cytology in this era is actually low specificity and low sensitivity. So what you want to do is send it for CEA. And interestingly, the statisticians must have had a field day when they came up with the cutoff of 192, to be exact, in terms of whether you're distinguishing serous cystadenomas from mucinous tumours. And CEA greater than 192 is indicative of a mucinous tumour. ERCP has a role as well. The main duct, IPMT, classically has that fish mouth appearance, and you may actually see mucin discharging from the main pancreatic duct itself. However, that's not going to be there in every case of main duct IPMT, and certainly ERCP isn't going to be of any benefit for a cystic tumour within the tail or even within the body of the pancreas. As I said already, PET unfortunately doesn't have a role to play in this condition. So let's look at these tumours in a little bit more detail. I want to look at the serous cystic neoplasm. Nothing to worry about. 3 or 4 anecdotal reports in the literature of cystic neoplastic tumours becoming invasive malignancy. And so serous cystic neoplasms are not something that we will cause undue concern about. Unfortunately, mucinous cystic, intraductal papillary mucinous tumours, and indeed the pseudopapillary tumours are a different story, and there is that malignant potential. So what do we notice about each of these in terms of characteristics? Well, as we can see, the mucinous cystic neoplasm tends to be in the body and tail. The serous cystadenoma, it can be anywhere throughout the gland, and indeed the pseudopapillary tumour, again, anywhere throughout the gland. If we look first of all at the serous cystadenoma, this gives very nice pictures, and our radiology colleagues quite enjoy seeing these sunblast or starblast appearances. EUS, you get honeycombing effect, and actually when you look at it, it can be quite characteristic to distinguish a serous cystadenoma. It's very common in the elderly population, and therefore an elderly patient with that type of appearance, serous cystadenoma. More common in females, and sometimes they may present with abdominal pain, weight loss, but as I say, in the majority of cases, it's an incidental finding. I thank Maurice Lockery for this nice picture, which really demonstrates what a serous cystadenoma looks like in gross specimen. And the other important factor with it is not related to the main pancreatic duct. These lesions do not communicate with the main pancreatic duct. For those that are interested in pink blobs, this is what the histopathology will look like in terms of simple strati throughout, simple columnar epithelium throughout the serous cyst. Moving on to mucinous cystadenomas, they pose a problem, and that is that they can range from being simple unilocular cysts right through to multilocular, quite large septated cysts. And as we can see in this diagram, or on this CT, on the head of the pancreas, this multiseptated large cyst. When do we become concerned? We become concerned when there is mural thrombus or there is mural thickening in association with that. And we can actually see in this endoscopic ultrasound view that there is mural thickening and thrombus within that mucinous cyst. That is a concern in terms of leading to invasive malignancy. Again, our female patients are more common. It tends to be a disease that we see around the 50s. It's younger than the serous cystadenomas, and the histopathology shows an ovarian stroma. And again, the cysts do not communicate with the pancreatic duct. Mucinous tumours are potentially pre-malignant. Now, when we look at main duct IPMT, the risk of becoming malignant is higher than that of branch duct. It is also higher than that of mucinous cyst neoplasms themselves. And actually, with main duct IPMT resections, nearly 25 up to 80% were actually found to have foci of invasive malignancy on the resected specimen. And this is what a mucinous cystic neoplasm looks like. The difference between the mucinous cystic neoplasm and IPMT is it does not communicate with the pancreatic duct. Again, we have a mucosal epithelium and ovarian stroma in a typical pattern for mucinous tumours, and this just highlights the glandular component to it as well. Moving quickly on to IPMT, this diagram really describes what IPMT is composed of. Main pancreatic duct dilatation in terms of main duct IPMT. This is what's called side branch IPMT. Simply, the cystic dilatation occurs in one of the little side roads off the pancreas. And then we have what is called a mixed IPMT, which is a component where we have a dilatation in the main pancreatic duct and we have multiple dilatations of side branches. The two that causes the most concern are main duct IPMT and mixed IPMT. And for the purposes of trying to stratify the risk, we put mixed and main together. They act one and the same. With these patients, there may be a long history of symptoms, but as everyone knows, pancreatic symptoms are very nondescript. Vague dyspepsia, back pain, a little bit of weight loss, a little bit of heartburn, and so sometimes this history can be going on for quite some time. Intraductal papillary neoplasia tends to be more common within the head of the gland, and as we said, mucin may be seen oozing from the ampulla of Vater. It connects to the pancreatic duct. Surgically resected non-invasive IPMTs have a really good survival. They have a 90% 5-year survival. And most of the recurrences in patients with non-invasive IPMT appear to come from those individuals who have multifocal disease. That is, cystic disease throughout the body and tail of the gland. If we look at the gross pathological specimen, you can actually see why it is that these are pre-malignant tumours. And you can actually suspect that even with this lesion here, there may be invasive malignancy taking place. Again, the component and the relationship to the pancreatic duct are critical. 1/3 of those patients with IPMT do have coincidental or invasive adenocarcinoma with the resected specimen, as we said. I want to look very quickly at pseudopapillary cystic neoplasm, and this is a very unusual tumour which really there's very limited information about. But the unfortunate thing for the pseudopapillary cystic tumour is that it occurs in adolescent females. Young girls in their teens, late teens or early 20s, presenting with a mass in the centre of the abdomen, and they have this large, quite distressing looking pseudopapillary cystic tumour. My first case of this was a young girl who was referred from the dermatologist who had started her on Roaccutane for acne and actually found that her liver function tests were abnormal. Sent her for an ultrasound scan, which unfortunately showed a gross, large cystic mass within the body of the pancreas. And so that young teenager was subjected to a distal pancreatectomy, splenectomy. The vast majority are young ladies. The female to male ratio is 10:1, and generally that symptom and history can be very nondescript. However, the outlook following surgery is excellent. There is only a small incidence of metastatic disease occurring in 10-15 years following the management of these patients. So if we collect the tumours together, we can see we have 4 subgroups, and each of them have some characteristics relating to location, pancreatic duct, and indeed the actual components of the cyst themselves. When we look back at CEA in our EUS aspiration, is it really helpful? Well, again, there's great debate. We have that 192 figure in our head, but does it really help us? And sometimes we have got to accept that a CEA level may not entirely give us the reassurance that we need. Whenever there's debate in surgery, we form consensus conferences. And there's several have occurred with regard to cystic tumours. And probably the one that we all relate to was in Japan in 2004. And the ruling decision from the management of these patients was that we resect all main duct IPMT. Mucinous cystic tumours, again, we generally resect those patients. Branch duct IPMT, we resect if they're symptomatic, if it's greater than 3 centimetres, and I'll come back to that, if there's the mural nodules I described, or if they have complications relating to the disease, jaundice, pancreatitis, etc. For those less than 3 centimetres, we generally observe them as long as there's no worrying features. That consensus was updated when the group from Europe basically gathered together to look at all of the literature in regard to cystic tumours of the pancreas and to try and update the Japanese recommendations. The problem is that, as with many areas in surgery, everything is not always what it seems. And that is exactly the case in terms of cystic tumours of the pancreas. So who can we observe? Can we observe these patients with cysts on their pancreas? And the problem is, it depends on the patient. Taking a tumour from the cyst or from the tail of a pancreas in a 40-year-old female is not the same as doing a Whipple's procedure for a tumour in the uncinate process in an 80-year-old patient. So although we have dogma that tells us we should resect IPMT, we should resect mucinous, we have got to put that into the context of the patients that we see in front of us. And we've got to ask that question, are these tumours pre-malignant? And if they are pre-malignant, how long does it take for them to become a malignant process? There is circumstantial evidence that suggests there's a lag phase of about 5 to 7 years between the benign component of it and the invasive component of it. But this is all based on pathological specimens. And also, I suspect we probably overestimate the rate of malignancy in these patients, and we overestimate the threat to our patients with these tumours. And so your 70-year-old lady with a cystic tumour in the pancreas that is pre-malignant, but maybe become malignant within the next 5 to 7 years, do we subject her to major surgery with a mortality of 5%? In the hope that she doesn't get a cancer in 6-7 years' time? And that's the challenge with regard to these patients. We talked about size, and size isn't everything. We used to think that 3 centimetres and below was good, that anything below 3 centimetres was not malignant, the chances of it becoming malignant were very slim. And actually, if we followed those patients up and looked for dynamic change in size, that was probably good enough. But even with size, there is very little to show in terms of the risk of becoming malignant. And likewise, there's very little evidence to suggest that bigger cysts are the only ones that become malignant. So even size is not really going to be of benefit. What happens to those people that you do observe? You do a scan within the first 6 months. You bring them back annually for a scan. What actually happens in terms of the follow-up? How many of those people went on to have surgery and at the time of surgery were found to have malignancy? And the answer is very few. Does multifocal involvement mean that they're more likely to get invasive malignancy? And again, there's no evidence to suggest that that is the case. Why do we not intervene, however? Because, similar to polyps within the colon, we want to prevent the development of cancer. And therefore, if we know that there is malignancy potentially, do we not go ahead and do it? And again, that is really where we have to come back to some points that will give us the higher risk of malignancy. And in our multidisciplinary setting, this is really what the discussion involves. Do these patients have symptoms? If they have symptoms, then there is probably an indication to do something interventionally. Do they have a mural nodule? Do they have worrying cytology? Again, non-specific, non-sensitive, but do they have worrying cytology? And is there major pancreatic ductal dilatation? So, ladies and gentlemen, I would say to you today that in terms of those people who have major pancreatic ductal dilatation, I would say they should have surgery. For those people who have mucinous cystic neoplasia not connected to the duct that is less than 3 centimetres, it may well be that we can consider simply observing those. Serous cyst adenomas, we don't want to touch. We leave those people well enough alone. But I hope I've emphasised to you that it is not as clear and as rigid as saying there's always the indication to operate on these people. In our own publication, we looked at the whole overall investigation and management of these people, and we tried to come up with an algorithm to try and look into all of the aspects of a cyst within the pancreas. And I'll very quickly show you that as you go down through this algorithm, you come to the bottom where you consider surgery. So that patient who has a cyst, who has no symptoms, but on EUS FNA has a high CEA, who has radiological features that we have described that would suggest one of those boxes of serous, mucinous, IPMT, or an indeterminate lesion. And then the final outcome of that is either we consider resection, taking the patient holistically, or we consider follow-up imaging. And again, what does that mean? How often do we follow these people up? In our practice, we do a further scan in 6 months. And then for those that we are worried have the sinister types of cysts, we will follow them up with an annual scan looking for increased size. Literature would suggest 2 millimetres of growth and more is obviously of concern. If we go ahead and resect, then we treat IPMT as if it's a pancreatic cancer. So we follow up for risk of recurrence. For the others, we simply have resected and leave well enough alone. We are seeing a massive increase in the number of pancreatic cysts. With that comes a lot of emotional energy because these people believe that they've got a sinister, life-threatening condition. We're seeing a lot more branch duct IPMT than we have in the past. But the key to the management of these people is to take each and every one of them as an individual, looking at their general well-being, the risks of the surgery versus the benefits, and looking at the characteristics of those cysts, which might help us identify those pre-malignant, likely to become invasive malignancies. But we have still so many unanswered questions. What is the right modality to use to follow these people up? Have we got the right interval? Do we need to be looking at them more often or less often? Do we need to follow them up at all? And really, we need to look back at the whole natural history. What does the future hold? Well, we hope the future for pancreatic surgery is better than the past because, unfortunately, we haven't made too much progress in the last 40 years in the management of cancers relating to the pancreas. But if we had a way of diagnosing those pre-malignant conditions easier or earlier, if we use KRAS mutations, if we look at other immunohistochemical ways, if we could predict that risk of transformation, if we can use other modalities rather than surgery, and we have heard from one of our previous speakers about electroporation and the use of other ablative techniques, which may be less insulting to the patients in major surgery. However, it has to be a multidisciplinary approach, and this is our hepatobiliary multidisciplinary meeting. Every Friday we do tend to meet, maybe not quite the way it should, but we do meet and we discuss all of these people, and that is the key to the management of each and every one of them. The surgeons, the gastroenterologists, the radiologists working through these people to try and determine who is the patient that needs that surgery.